Hello, my name is Makoto Mori. I'm an associate editor at JACC, and today I have the distinct privilege of being with Dr. Sardari, who has conducted this incredibly challenging trial, the digital cardiac counseling trial that is going to be simultaneously published at JACC with the EACTS presentation. So Dr. Sardari, welcome and thank you for taking the time to be with us today. I wanted to start off by asking you to describe your study.
Thank you for the kind invitation and the opportunity to talk about this trial. So trial is basically a randomized control trial of almost 400 patients, 394 patients. And the trial is focused on the effect of prehabilitation, which was provided to the patients as a mode of telemedicine, teleprehabilitation, to reduce the known risk factors that we know that are modifiable, and to test the hypothesis whether you can decrease the major adverse events after cardiac surgery. So patients were randomized who were waiting for elective cardiac surgery, and they were screened for different risk factors, namely the physical fitness, the pulmonary risk score, HAT score, which is a focus on the psychological things like anxiety and depression, the nutritional status of the patients, and the smoking status. And then patients were provided in the randomized intervention group a multimodal prehabilitation modules based on their risk factors, and which were guided by shared decision making to see whether we could decrease the number of adverse events happening postoperatively. In general, the results show that there is a significant difference in favor of intervention group, reducing the major adverse events by absolute 8.8%, which is actually almost 35% less than in control group. What is unique about this trial is that it not only provided the results on the effect of teleprehabilitation, but also provided some evidence that prehabilitation is also safe, because the endpoint was included from randomization up to 1 year postoperatively. So this included also the waiting time for cardiac surgery. And notably, there was no difference before the index surgery between control group and intervention group with regard to the incidence of adverse events. Additional to that, what is also important is that obviously we addressed known risk factors, and we provided also data that you can reduce the risk of patients by this teleprehabilitation before index surgery. So in many aspects, this trial is unique because in somehow this trial empowers patients and provides them the tools to get ownership about their health status before undergoing a major procedure. And by doing so, they reduce the adverse events without any trade-offs.
Nice. Yeah, thank you very much for the description. I think the editorial board and the reviewers are all very enthusiastic about this trial. When we first received this, it's such an important topic, and it was a very well-designed trial. And I thought one of the clever aspects of it was that you were able to demonstrate which modifiable risk factor actually went down from the randomization to the time of surgery. And by doing so, you were able to point out specific factors that may have contributed to the reduction in the incidence of the outcome. And I believe the main sort of driver in the reduction in the composite event was a hospitalization. Was that what you observed?
Yeah, so if you look at the numeric results that we have, obviously this was a composite endpoint, but the major benefit was in rehospitalization for heart failure or other major cardiac events. That is correct. And which is also a bit logical in a sense that perhaps if you undergo a major cardiac surgery, um, maybe not directly you can influence the mortality, but you can influence the complications by which patients are required to get hospitalized. But obviously the composite endpoint was also chosen to show the safety of the trial. So, I mean, the MACE, it was a composite endpoint, and it is not the conventional MACE because we added rehospitalization, but also we added early intervention or surgery. Because if you wouldn't add that, you wouldn't be able to detect those who are waiting for cardiac surgery because of the trial or because of prehabilitation, and they have an event that is not included in the endpoint.
I see. Yeah, thank you. So as you stated, there's really no penalty in the patients who can wait to undergo this prehabilitation process. That's more power to the trial, I think. So I wanted to switch gear and ask you about the backstory of this kind of landing on conducting this incredibly challenging trial. I wanted to hear your thoughts and your team's journey.
So this is very interesting because it was in March 2020, and you know this the start of COVID, and we stopped almost operating. So we had a waiting list, and I was sitting in my office and thinking, we need to do something with this. We need to offer patients something, but also we need to take this opportunity to conduct a trial on prehabilitation. And and this is an investigator-initiated trial, and the design of the trial reflects a really curiosity, because when I designed this trial at that time, nobody would believe that you could find a difference in MACE with prehabilitation. And if you look at all the trials published to date, they are not on the major, adverse events. But my idea, and then also from the team, because this is a process of teamwork as well, was if we are going to set up this program, an online program, we put such an effort in it, we should be also honest to see whether there is an effect which is clinically relevant. So that is a bit of backstory of the trial. And the other was that we were some years involved in producing some sort of online program for education of patients. And we had already a groundwork for that, which made it easier to actually build a custom platform in 6 weeks to get it to through the ethical committee and start recruiting patients. What is also important for us was very important to have a trial which patients would benefit by participating, but also make sure that there is a absolute safety for the patient. So in the prior, so in the preoperative phase, all patients were screened weekly by New York Heart Association class and also Canadian cardiovascular score. So for the dyspnea and to detect any issue with patients who have symptoms and help them earlier. And the other one was that we included in the digital platform also material to educate patients about their process of care, the operations that they were undergoing. That was video and animations about different kind of operations that they underwent.
I see. Thank you very much. So for those of us who read this article and listen to this interview, perhaps, what would be the take-home message? What can we take information and bring it back to our center and implement?
So obviously, if you based on the trial results, which in the randomized controlled trial you need to be very specific, is one, prehabilitation is safe, and second is patients benefit from prehabilitation by reducing the risk factors, and because of that they have less chance to get an adverse event postoperatively. This is just very briefly what the results of the trial show. But if you go and look at the trial's setup and data, what is also important to note is 98% of the patients had at least 2 modifiable risk factors. 98%. Like 87% they were physically less fit, 45% they had a higher pulmonary risk factors, 45% they had anxiety or depression, around 25% they had obesity, and over 10% they were active smokers. So these are risk factors that you can do something about. And it is not, the effect is probably, obviously this is a trial that we measured an endpoint for 1 year, but you can imagine that, and we will follow up on that, if you stop smoking for 1 year, at the end, this is something that's going to be last more than 1 year. And the effect on the healthcare is much longer probably. So by simply empowering patients to work on the risk factors, and they are motivated because preoperatively they are undergoing a major cardiac surgery, so they are much easier to be motivated to do something about that, and that can be lasting, which is very, very important. The other thing is this is a trial that provided the care through teleprehabilitation. Obviously, there is a problem of a lack of facilities. There are many problems in the healthcare, costly, but if we can move that to the patient and to their homes with something which is workable, this is also going to benefit the healthcare in general. And I think this is something also, this kind of programs are also interesting for other disciplines.
I see. Thank you very much. I think the great attention to the implementation aspect of this is also very unique and makes the trial all the more powerful. So thank you for sharing your time with us, and congratulations again on your trial.
Thank you for giving us the opportunity to talk about this trial. Thank you.